You can share your PPT and start your presentation. Hi, sir. Karnakaran, sir. Sorry, sir. Srinivasan, sir. Good evening, sir. Am I audible, Srinivasan, sir? Sir, you are in mute mode.
Yes, sir. Yes, sir.
Sir, I request you to also join and conduct today's program, sir. I'm out in the Harvard. So I'll be joining now and then, sir. I request, I told Sahai, sir, Karnakaran, sir also. I request you to please conduct the day's proceeding.
Yes, sir.
Thank
no
you.
problem, sir.
Thank you. Thank you. Dr. Deepthi, please. Srinivasan, sir, and Rajiv Sagai, sir, I'm making you co-host so you can handle if there is any problem, sir. Please make it full screen and start your presentation. Ma'am, we are unable to see you, Dr. Deepthi.
Yes.
I'm able to see her, sir.
Okay, good, sir. Now I'm getting it.
Yes, sir.
Please make it full screen. The faculty will conduct the proceedings.
Yes,
good
sir.
luck to you.
Thank you, sir. Just a minute, sir. Just taking time.
You have some challenges?
Yes, sir. It's not going to full screen actually.
Please unshare. Please unshare.
Yes.
If in case you slides are not moving.
Yes, sir. That's the problem.
Okay.
Actually.
You please first unshare the screen now.
Yes, sir. Let me.
Now you share the PowerPoint again. Hitesh, sir, good evening, sir.
Good evening, sir. Where are you?
I am at Harvard, sir.
Hats off to you. Hats off to you.
Thank you, sir. Thank you very much.
Unbelievable. No one can do this.
Are you, sir? You're all there to help me. What am I doing, sir? Nothing.
That's different issue, sir. But I don't think anybody else would have even thought of this.
Sir,
After our Prime Minister, if anybody is working so hard, that is only you.
Sir.
Hitesh, sir, your backdrop is very good.
Well,
Thank you, sir. Thank you.
Dr. Deepthi, you are ready, ma?
Yes, sir.
Yeah, you are able to.
That is, I think, Bengal, Murshidabad. I went for an inspection and went for a local sighting. There I took
Yes,
the
sir.
photograph.
Nice, sir.
Dr. Deepthi, please start. Faculty is
Yes. Yes, sir. Good evening, everyone. Myself, Dr. Deepthi Singhal, second year general surgery resident from BJMC.
Invited faculty have come, sir.
Sir, Narendra Ganguly, sir, is joining. Dr. Swagta is still finishing the surgery, sir. The postgraduate called up. I requested both yourself, Dr. Hitesh, sir, Sakai, sir, and Karnakaran, sir, to conduct the proceedings, sir.
Yes, sir. Yes.
Let them join, sir. I don't want to get delayed.
Okay, no problem.
Yes, sir.
Another process.
Thank you.
Sri Rao has somebody has joined.
He is from Tirupati, sir. Welcome, Sri Rao, sir.
Sir, please, you can also take over, please. Yes, sir. Prasanna, sorry for interruption.
Should I start, sir?
Yes,
Please,
please.
ma'am.
Sorry. Yes, Deepthi, sorry.
Yes. Myself, Dr. Deepthi Singhal, second year general surgery resident from BJMC Ahmedabad Civil Hospital. I am presenting a case on inguinal hernia under the guidance of Pankaj R. Modi sir, head of my unit, Maulik B. Mehta sir, associate professor, Hardik B. Bhatt sir, associate professor, and Dipali A. Sadhu, assistant professor of my unit, sir. 58-year-old male patient from Nicole, Ahmedabad, working as a tailor, presented to the OPD with the chief complaints of swelling in right groin region since last 2 months and pain in right groin region since last 15 days. History of present illness. Patient was relatively asymptomatic before 2 months. Then he noticed the swelling in right inguinal region at the time of the straining, and the swelling gradually increases to the present size and which is confined to inguinal region only. Swelling became prominent on standing and coughing and does not disappear spontaneously on lying down, but patient is able to reduce it completely. Patient complains of aching pain over the site of the swelling since 15 days, increases at the time of the straining and coughing. History of present illness. There is no history of chronic cough, no history of constipation, no history of urinary hesitancy, urgency, or increase in night frequency. There is no history of fever, vomiting, and abdominal pain. Past history. There is no history of diabetes, hypertension, or tuberculosis. There is no previous operative history. The patient is not addicted to smoking or alcohol. Patient is having mixed diet with normal appetite, and bowel bladder habits are normal. And there is no significant family history, sir. Summary of my history is 55-year-old male patient presented with chief complaint of right groin swelling since last 2 months, which is gradually increases in size, become prominent on standing and coughing, and does not disappear spontaneously on its own on lying down, but patient is able to reduce it. Patient complains of aching pain over the site of the swelling since last 15 days, and pain increases when swelling becomes prominent.
Okay, Dr. Deepthi, let's go to
Yes,
your slide, please.
Next one, sir.
No, first
No,
slide.
your history, man.
Yes, sir.
Since 2 months, since 15 days,
Yes, sir.
if you know the time, right?
Yes,
then
sir.
it is for so, if you don't know the time, it is for so many days, right?
Yes, sir.
If you know the time, then it since 25th, since,
Yes.
right? But
Yes.
for 2 months,
Yes, sir.
you get? Okay.
Yes, sir.
So he has
Yashikan
swelling
sir,
in the
good
right
evening.
groin and
Yashikan
pain
sir,
in right
good
groin.
evening.
Okay, next slide. Okay.
One more thing I like to add. In history, you are mentioning groin region, and in present illness, you are mentioning inguinal. By and large, most examiner will accept inguinal region, but better to use in layman's term when you have started using groin, continue with groin only.
Yes, sir.
Now the patient
These are
complains
just
of pain.
nothing else.
Yeah. Why do you think the patient is having pain now since 15 days?
Sir, patient came to the OPD mainly because of the pain only. Swelling was present since last 2 months, but patient having no complaint of pain. But now the pain is present, so that's why patient wants to get treated.
That's fine. That's fine. That's fine. That's fine, Deepthi. But why do you think he's having pain now?
Sir, because of the stretching of the abdominal walls and because of the nerve compression, sir.
Which nerve compression is happening that is getting pain?
Sir, ilioinguinal nerve and iliohypogastric nerve, sir.
So if the ilioinguinal nerve and iliohypogastric nerve is irritated, where do you get the pain?
Sir, over the groin region and just above the scrotum, sir, at the region of pubic tubercle, sir.
Okay. Okay. Any other cause of pain? This is uncommon. Any other cause of pain?
Because of the contents and the stretching of mesentery.
Mesentery is painful, is it?
Yes, sir.
No, it's the parietal peritoneum which is
Yes, sir.
painful. Okay.
Yes, sir.
Mesentery has got sympathetic supply. So
Yes.
it is, and it's the parietal peritoneum which has got a somatic supply. Others got
Yes.
an autonomic. Okay,
Yes.
next slide, please. Why do you take history of fever, vomiting, and abdominal pain when you said that it reduces on lying down?
So, sir, to rule out the complaint of obstruction or
So
strangulation.
is the patient in obstruction?
No, sir, patient doesn't have obstruction.
And it doesn't matter. I mean, just for completion, it doesn't. If you think that it was obstructed, then take.
Yes, sir.
Otherwise, you can take history for so many other things.
Yes, sir. Yes.
Okay. Next slide, please. Operative history. Which surgery did you specifically ask for?
So for the history of appendicectomy, I will ask because in appendicectomy, the ilioinguinal nerve will be injured in that case, and it will lead to the weakness of the abdominal
Okay, that's
muscles.
fine. Any other surgery?
Previous hernia surgery.
Okay. Any other surgery?
For prosthetic surgery, sir.
Okay, good. Family history. Why do you take history of family history?
Sir, to know the any history of the muscle weakness or an collagen deficiency, because in these cases the muscle will be weak and there will be the poor tone of the abdominal muscles.
Okay. Otherwise, also, can it run in the family?
No, sir, it doesn't run the families.
It can. It can. It's been seen. There's no reason for it, but it's been seen that there's a high incidence. Okay. Next slide, please. Okay. So, what do you think is the diagnosis now?
Sir, my diagnosis will be right-sided indirect inguinal hernia, which is reducible.
Why
And,
did you say indirect straight away? How do you know it's
sir,
indirect?
Sir, because on lying down, the swelling does not disappear spontaneously. The patient has to reduce it manually. And in case of direct hernia, mainly the swelling will reduce spontaneously on lying down and appear immediately on cuffing. But in case of indirect hernia, it will take time to come out, and the patient has to reduce it manually on lying down, sir.
So you think all indirect hernias have to be reduced by taxes?
No, sir, not all indirect.
Then how have you come to the diagnosis of indirect? Look, indirect, you can't just say it like this, okay?
Yes, sir.
You should just say do you think it can be a femoral hernia?
Yes, sir, it can be femoral hernia if it is present below and lateral to
No,
pubic
if it
tubercle.
is, no, by history, we're just talking of history.
Yes, sir, it is. It can be.
So why did you say it's just an indirect inguinal hernia? So, okay, you can say that it is a hernia in the groin region, probably
Yes, sir.
an inguinal hernia.
Probably.
Yes, sir. Yes,
Don't commit yourself at present.
yes, sir.
So,
But I think, sir, she can also say probably indirect.
yeah, probably.
Yes,
Okay,
again,
yeah.
you have to use probably. Yes.
Yes, sir.
Probably. You can't commit yourself.
You can't commit. Yes. You don't say my diagnosis is in indirect inguinal hernia. You say that my probable diagnosis is inguinal
Yes.
hernia, more likely to be indirect hernia. This is how you can say. So
Yes,
when you
sir.
say probable inguinal hernia, that means you are not ruling out femoral, and more likely indirect, not ruling out the direct as well.
Yes, sir.
Deepti,
Yes, sir.
would you please go back to the past history slide?
Yes, sir.
See, in past history, there is no operative history.
Yes, sir.
Yes.
Yes, sir.
See, while doing appendicectomy, if at all we injure ilioinguinal nerve, that leads to weakness of the muscles.
Yes, sir. Yes, sir.
What is triple neurectomy?
Sorry, sir, I can't hear you.
Triple neurectomy.
Sir, for triple neurectomy is cutting off ilioinguinal nerve, iliohypogastric, and genital branch of genitofemoral nerve.
That is what I used to do whenever I do inguinal hernia surgery. I used to cut all these nerves. So Among these nerves comes the ilioinguinal nerve. So is it not a paradox? So when you cut the inguinal nerve while doing appendicectomy, it produces weakness of the muscle and hernia. Whereas I
Yes, sir.
deliberately cut it while doing inguinal hernia. There, how can you explain this?
Sir, if we cut all the three nerves in operation of inguinal hernia, there will be the less chances of chronic inguinodynia pain. So to avoid this complication, we can deliberately cut all the three nerves.
My question is it not a paradox? See, you should not while doing appendicectomy. That's what we advise. Whereas we
Yes,
are
sir.
cutting while doing hernia, raphia or hernioplasty.
Yes, sir.
How can you explain that?
One is the cause, one is not the cause. We are doing deliberately. Why it is so paradoxical? This is what sir is asking.
See, the point is
indication for why sir is cutting the nerve and proceeding further. So sir is facing some difficulty. Or why is he cutting it? That's what he's asking in the form of paradox. If you answer, or sir will answer.
As you said, we cut this nerves in order to prevent the entrapment of the nerves while placing the mesh, which
Yes,
may
sir.
leads to inguinodynia or whatever it is, pain related to that. Whenever we cut the ilioinguinal nerve in the inguinal region, it carries only sensory fibers. Whereas
Yes, sir.
when you cut it at a higher level, that is at the incision level of appendicectomy, it carries both motor as well as sensory fibers. So when you
Yes,
cut
sir.
it while doing an appendicectomy, the motor fibers also cut. So that leads
Yes,
to
sir.
weakness of the muscles. Okay, that's the explanation.
Yes, sir. Yes.
Sir, anybody want to chip in? You can please.
So,
chip in,
Dipti,
sir.
which hernia will occur? Dipti,
Yes, sir.
which hernia will occur? Direct.
Sorry, sir, I can't hear you.
Professor
Sir, the voice
Nishikant,
is-
sir, you are not audible.
Which hernia will occur?
Which hernia will occur if you cut the ilioinguinal nerve? That's what your question, sir.
Sir, inguinal
Ah, yes,
hernia,
sir. Yes, sir.
direct,
Direct
sir.
or indirect?
Direct, sir.
Okay.
Okay, Dr. Dipti.
You understand? We understood what Professor Karnagaran said.
Yes, sir.
So before the ilioinguinal nerve enters the canal, it
Yes,
gives us all the supply to the muscle and other thing.
Yes, sir.
So inside the canal, it doesn't give any tweaks to the skin. That's why you don't get a hernia if you cut the ilioinguinal nerve in the canal. You have only a sensory loss.
Yes,
If
sir.
you have a sensory loss, where do you experience the sensory loss?
Sir, over the root of the scrotum and in the inguinal region, sir. Towards the
Medial
medial
aspect
side.
of the thigh and
Medial
scrotum,
aspect, sir.
and
Yes, sir.
female the clitoris or labium. That
Yes,
is
sir.
very cumbersome for the females if you cut. So
Yes,
as far as possible, try to preserve.
Yes, sir.
Yes, sir. Professor
Dr.
Nishikant, sir.
Dipti, Dr. Dipti,
Yes, sir.
suppose it was the left-sided inguinal hernia. Can any
Yes, sir.
surgery lead to inguinal hernia, or which surgery can lead to inguinal hernia is done on the left side, similar to the appendicectomy on the right? Which surgery usually done with similar incision?
I don't know, sir.
Similar
See, it is not
incision
the
like
surgery. It is
left
not the
side.
surgery, it is the incision which leads to
Incision,
damage,
similar incision.
right? Similar. And one thing is, you should also ask whether the surgery was straightforward or not, whether the incision is small, because muscle containing incisions are more likely to damage the nerve rather than regular muscle splitting incisions.
Yes, sir.
So you
So any
can say that rather than appendicectomy, no history of any lower abdominal surgery
Yes, sir.
on that side.
Yes.
Or you
So
can
usually
specifically
approach
say,
to the lower ureter, approach to the lower ureter and bladder
Yes,
yes.
sir.
can also cause.
Yes.
Should we go to the examination, sir? Okay, examination, please.
General examination. Patient was examined after taking informed consent in well light and with proper exposure. Patient is conscious, oriented to time, place, and person. Temperature is normal. Pulse rate is 90 beats per minute and regular. Blood pressure is 110 by 80 millimeter of mercury in right arm in supine position. There is no pallor, cyanosis, icterus, and lymphadenopathy. In local examination, patient was examined in supine and standing position. In standing position, 7 into 4 centimeter piriform shaped swelling is present in right inguinal region and does not spontaneously disappear on lying down, but patient is able to reduce it manually. Expansile cuff impulse is seen. Smooth surface of the swelling with skin over the swelling is normal. No visible peristalsis and there is no deviation in position of penis. In supine position, swelling does not disappear spontaneously, but patient is able to reduce it manually. Left inguinoscrotal region is normal, sir.
Okay, go ahead, move it. Move it.
This is the video of the cuff impulse, sir. Should I start?
Okay, move it. Move it.
Yes.
Only on one side or both sides? No?
Sir, only one side, sir.
Video, I doubt. Okay.
Yeah, I mean, you said it does not reduce spontaneously lying down. Such a small hernia I don't see any reason why it should not reduce on its own. Anyway, yeah, go on. Not important though.
On palpation, temperature over the swelling is normal. No tenderness is noted. 8 into 4 centimeter piriform shaped swelling in right inguinal region. Surface is smooth with elastic consistency. Expansile cuff impulse is palpable. Swelling decreases in size on supine position and completely reducible manually with gurgling sound. On deep ring occlusion test, swelling does not appear, that is positive, and external genitalia are normal on palpation.
Go on.
On systemic examination, per abdomen is soft, non-tender with no organomegaly. Rest of the hernial sites are normal. Per rectal examination is normal. Tone of the abdominal muscles are good. Respiratory system, bilateral air entry is normal. Cardiovascular system is S1 and S2 are audible. Central nervous system, patient is conscious and oriented.
Okay, no, go on.
Should I continue?
Go on, Dr. Jyoti.
Yes. 55. My summary of my case is 55-year-old male patient presented with chief complaint of right groin swelling. Since 2 months, gradually increases in size, become prominent on standing and cuffing, and does not disappear spontaneously on its own or lying down, but patient is able to reduce it completely. Patient complains of aching pain over the site of the swelling. Since last 15 days, pain increases when swelling becomes prominent. On examination, a single piriform swelling in right inguinal region of 8 into 4 centimeter size associated with pain. It is manually completely reducible with gurgling sound. Expansile cuff impulse is present. Swelling does not appear on deep ring occlusion test and external genitalia are normal.
Okay, Dr. Deepti, regional examination. Let's go back to your regional examination.
Yes.
No visual peristalsis on standing. Okay. This your inspection on standing.
Yes. Yes, sir.
appears
I have done
does
the
not
inspection on standing.
reduce. So this visual peristalsis is on standing, is it?
Yes, sir.
And why deviation of penis, position of penis, is it important here? How does it help you in your examination, or you come to a diagnosis?
Sir,
Does
it will be, if the swelling is large, sir, in that case, it will be
Your swelling
important.
is not very large. You
Yes,
just
sir.
go show us the picture. Show us the picture.
Yes, sir.
Hardly any swelling. I mean,
Yes.
it doesn't make any difference. Okay, let's go back. Let's go to forward.
Yeah.
Next. Okay.
Hello.
You said no.
Deepti.
Just go back. External genitalia, you said is normal.
Yes, sir.
What particular thing will you look for in external genitalia?
Sir, we'll look for the scrotum and for the testes, sir.
So you have to mention whether both the testes are there or not.
Yes, sir.
You could just can't say external genitalia are normal and walk away,
Yes.
right? Also,
Yes, sir. And also,
did you examine the
Even per rectal examination, you have to mention the size of prostate and whether it is enlarged or not.
yes, sir.
Right? He is 55-year-old male.
Yes, sir.
So he may have started some symptoms.
Yes, sir.
also you must? Did you see the meatus, external meatus?
Yes, sir. Yes, sir. I've seen the meatus and palpate for the bulbal urethra and to
So, Dr. Deepti, you have to mention this, right?
Yes, sir. Yes.
This is important. You must examine the scrotal
Yes, sir.
skin anteriorly and posteriorly,
Yes, sir.
right?
Yes, sir.
Dipti,
Did,
Yes, sir.
sorry, did you
you
examine
have
the
not
back?
mentioned relation of the swelling to the.
Sorry.
Hello.
Yes, sir.
Yes, sir, you are audible.
You have not mentioned about relation of the swelling to the inguinal ligament and pubic tubercle. What is significance of this?
Sir, it will be important to differentiate between the inguinal swelling and the femoral swelling. In case of the inguinal hernia, it will be medial and above the inguinal ligament. And in case of femoral hernia, it will be below and lateral to the pubic tubercle and below to the inguinal ligament, sir.
You have not mentioned in your
Yeah.
local examination. You have to mention it.
No, sir, I have not mentioned.
This comes under the protocol.
Yes.
Then what is location of deep inguinal ring?
Sir, deep inguinal ring is present ½ inch above the mid-inguinal point. Mid-inguinal point is in between the anterior superior iliac spine and pubic symphysis.
And what is midpoint of inguinal ligament?
It is in between the anterior superior iliac spine and the pubic tubercle, sir.
What is
So
anatomical landmark?
The
what
first
lies
we have,
underneath the
Inguinal point and midpoint of inguinal ligament. What are the anatomical landmarks?
at the
Femoral
when the
vessels are like at which level?
Midpoint of inguinal ligament, what is the important structure you look for?
so for the femoral pulsation, I will
Yeah,
look for.
the external iliac continues as the femoral below the midpoint of the inguinal ligament.
Yes, sir.
Right. Mid-inguinal point is different.
Yes, sir.
Where is the deep ring actually? In which anatomical layer is the deep ring?
Sir, it is the modification of fascia transversalis, sir.
It's a small.
Not
What is the shape of?
modification.
Not modification.
Not
It's a
modification.
small what is the
It's
size?
not-
What is the
small
shape of the
defect in-
defect?
Sir, it is a U-shaped defect and fascia transversalis, sir.
Okay.
External ring?
Sir, it is a triangular shaped defect in external oblique aponeurosis, sir.
It's an inverted V shaped.
Yes, sir.
Two crura lying this one like this.
Yes, sir.
Okay. So that is
So how will
okay.
you look at the external ring?
Yes.
Location of external ring?
Sir, it is present 1.25 centimeter above the pubic tubercle.
And regarding mid-inguinal point and midpoint of inguinal ligament, which point is medial and which point is lateral?
Sir, inguinal point will be medial and midpoint of inguinal ligament will be lateral.
Okay, Dr. Dipti.
Yes.
Did you examine the patient's back? The spine? Okay, I think you should. You should. Right? If there's any tenderness. Right?
Yes, sir.
Also, you said this about pain, but in your history, if not, or your history, you have not quantified the pain. What is the kind of pain?
Sir,
Whether
it
there's
is-
any radiation, whether there's any, the mnemonic Socrates should be complete.
Sir, it is an
Size,
aching
origin.
type of pain and it is
Yeah.
non-radiating, sir.
So all that has to come down. Okay.
Yes, sir.
Right. So now let's come to your diagnosis.
Yes, sir.
Deepti, let me ask 1 or 2 questions.
No,
Yes,
sir said Socrates. I don't get, sir. Please kindly repeat, sir.
It is site, origin, character,
Right, origin,
radiation,
radiation,
Oh, right, sir. Right,
Mnemonic.
sir.
mnemonics.
Jailal, sir. Welcome, sir.
aggravating factors, relieving
Yes, sir.
factors.
Professor Ganguly sir has joined.
Deepthi?
Sir, Ganguly sir, welcome.
Yes, sir.
Thank you. Thank you very much.
Yeah, please,
My-
please take. You can also.
Yeah,
Please, sir.
I'll ask you, but now I'm not finding any question because everybody is asking only. And my camera is causing a little bit problem. Video is not loading. So I'll be hearing and talking.
You are audible, sir. Thank you, sir.
Yeah, thank you. Thank you. I'll ask question when I feel like
Yes,
you
sir,
are
yes.
asking. I'm listening only. Yeah.
What do you mean by groin?
Sir, it is the point of junction between the lower abdomen and thigh region, sir.
There is a line. It's a junction. The hernia is your swelling is at the junction.
It is a region between the joining of lower abdomen and thigh, sir, in between.
So which region it is there? The femoral region is also groin.
Sir, the external genitalia region and the inguinal region, sir, and femoral one.
So where is the swelling? You are again repeatedly using again groin swelling. But what do you mean by that? By the end of the day, we cannot differentiate whether it's a femoral hernia. So why don't you use the word inguinal region? Is it an inguinal swelling or inguinal scrotal swelling? Or where is the swelling?
So the swelling is in the inguinal region, sir.
Only inguinal.
Yes, sir, fully inguinal, no scrotal extension, sir.
So how do you get a pyriform swelling in the inguinal region?
But extending the pyriform shaped has become because the swelling came from the deep inguinal ring and then when extend into an inguinal canal, it forms a shape of pyriform because the apex and the stalk will be in the deep inguinal ring. Sir.
It is confined to the inguinal region. It is not coming into the scrotal region. It can be either oval or a round only. Only when it comes into the scrotal region that you will be able to see a pyriform shape swelling.
Yes.
So you must be very careful in saying that where the swelling is confined.
Yes, sir.
Don't use a vague term. And the swelling is spontaneously reducing, no?
No, sir, the swelling when on lying down, patient has to reduce it manually, sir.
So what is the position he adopts?
Sir,
For reduction?
adduction and internal rotation of thigh, sir.
Why do you want to adduct? What is the muscle of adduction and why do you want to adduct?
Sir?
What is the purpose of adduction?
So it will relax the superficial inguinal ring and the muscles of the abdomen, sir. 2 crura of the superficial inguinal ring will be relaxed in this position, sir.
No. What is the relationship of your adductor muscle and the superficial crura? Which muscle you are adducting? What is the muscle of adduction of the thigh?
Sir, adductor magnus, longus, and brevis. Sir.
Magnus. You are interested in adductor magnus. So in what way adductor magnus helps in the superficial inguinal ring? So each position when the patient adopts, there's flexion, internal rotation, and adduction. All three has a purpose of why you should do. Adductor longus, where is it inserted? Attached to where? It is attached to the pubic tubercle.
Yes,
The
sir.
crura is also attached to the pubic tubercle. If you adduct,
Yes, sir.
it pull on the pubic tubercle and the crura will be relaxed. Flexion is going to make the internal abdomen wall relax and open.
Yes,
Internal rotation makes the openings in the straight line.
Yes, sir.
The line it is going to. So all these three are important for you to do that.
Yes,
And
sir.
what is the gurgling sound you hear?
Sir, when the content of the sac is intestines and when we reduce it, there will be a gurgling sound on reduction, sir.
So have you heard the gurgling sound?
Yes, sir.
Please be careful when you are saying that in the examination, examiners will examine the case and come. It is very unusual you get a gurgling sound for just a swelling which is only in the inguinal region. And if you really hear that swelling, please mention that, not for just for the routine, like just for the undergraduation. Don't use that word, gurgling.
Yes.
Okay? Okay.
Yes, sir.
Gipti, one question I want to
Yes,
ask. How to perform the finger invagination test?
Sir, in
Ring
finger
invagination test?
yes, sir. In finger invagination test, we have to direct the index finger toward the pubic tubercle and then direct the index finger toward the superficial inguinal ring.
Patient position.
Sir, first we have to reduce the hernia and the patient position will be the standing, sir.
Which finger is used in adult age group? Which finger is used in pediatric age group?
Sir, in pediatric age group, little finger will be used and in adult age group, index finger will be used.
Okay, then
Then we will direct the finger towards the superficial inguinal ring and ask the patient to cuff, sir.
directly
And
towards superficial inguinal ring, or you have to palpate something?
first we have to palpate the pubic tubercle and then
Okay.
from that I have to direct my finger towards the superficial inguinal ring, sir.
And turn your finger so that
Yes, sir.
nail faces towards the spermatic cord. Then next,
Then I will ask the patient to cuff. If the swelling is palpable at the swelling is feel
no,
at
no,
the
no, no,
pulp
no, no.
of-
Other points are also there. Other points are also there. First, you have to see the size of the ring.
ring. Yes, sir.
Then condition of the crura.
Yes, sir.
Then next,
The tone of the muscle and the two cruras, how they are approximated, sir.
direction of the finger.
Yes.
In direct hernia, where the finger will go, and in indirect hernia, what is the direction?
Sir, in direct hernia, patient, in case of indirect hernia, the finger will go towards the lateral side, sir.
So for the
How
both
it is
two
classically
hernias, the
mentioned in book?
direction is different. Is the finger direction is going to be different for both the two hernias?
Directly
Maybe.
backward in case of the direct hernia.
Yes, sir.
Outward lateral and backward is in
Towards
case of indirect hernia.
Yes, sir.
Have you done the test?
Yes,
No,
sir, I have done the test.
No, Professor sir, and we have been talking. Now it
Please
has not
don't-
been done. If you say not done, we will accept. It is not
Please-
done nowadays.
Please don't do that.
I think in our institution, if you are taught, you tell, but otherwise it has not been done. That one a knee elbow position
Yes.
not being done. Okay.
But most of the time, examiner will ask you,
Yeah,
Yes,
if
sir,
someone
yes,
asks you, you
what
have to
is the
say.
finger examination test?
Yes, sir.
And how to
That's the
perform.
only
And
test done
teacher
in the
will
lying
be able
position.
to know, able to explain the points, all points in this test.
Yes, sir.
Dipti?
Yeah, and that is the only test done in the lying position. Other two tests are done in this standing position.
Yes,
These-
sir.
It's the only
these
test
tests
done in
has-
the lying down position. You
these
take your
tests
finger
you have done
anterior.
that with the standing posture.
Sir?
And you never do that test in the standing posture.
Yes, sir.
Yes,
Yes,
sir.
sir. That's what I'm correcting here. You take the finger like this in a supine one, go inside, touch the pubic tubercle, pronate your finger, and show the
Yes, sir.
see. As sir said, go feel for the fingers, sorry, the ring,
Yes, sir.
and also ask the patient to cough.
Yes,
But
sir.
if somebody asks, you have to tell, but it's not done nowadays.
Yes.
Okay, right. Thank you,
How do you
sir.
find
Sir,
out it is
agree.
expansile cough impulse is there? How
Yes,
did you
sir.
made out the expansile cough impulse in this case? You said you were swelling is an inguinal swelling.
Yes, sir.
How do you made a expansile cough impulse?
Sir, I will put two fingers at the
Where? Where do you pick the two fingers?
yes, sir.
Where you have
Two-
kept the two fingers?
Sir, to check for the expansibility and increase in the size of the swelling, sir.
I'm asking you now. You have reduced the swelling. Now where you are keeping the finger? Two fingers where you are keeping?
Sir, at the point of the deep inguinal ring, sir.
Deep inguinal ring. So suppose it is a direct hernia. So hernia is one very, very important. Each hernia, which what we are interested in your clinical finding. How you are doing to do the each clinical test is important. Don't just say just as a routine. And
Yes, sir.
try to practice the case. Every case you're going to do, especially when a very swelling is only in the inguinal region. how you are going to do. When it comes to the inguinal region, it is easy. You can hold the card stretches and see that at that region. Otherwise, you have to keep the swelling, 2 hands, 2 fingers over that, and lifting and spreading. You have to see.
Yes, sir.
Deepti,
Okay.
Yes, sir.
Okay.
I want to ask 1 or 2 questions from the point of examination of external genitalia. Will you please put the slide? Yes, you said the external genitalia. I don't know. I don't need the picture. You just go to the slide.
Yes, sir.
External genitalia are normal. Yes.
Yes, sir.
What
Yes, sir.
are all the things you are supposed to examine in external genitalia?
Sir, in external genitalia, I will look for the scrotum and I will palpate both the testes. I will see for the external urethral meatus. I will see the palpate the bulbar urethra to look for any stricture in the urethra, sir.
See, what are all the 4 parts of male urethra?
Yes, sir.
4 parts of male urethra.
Sir, penile urethra, prostatic, membranous, and bulbar urethra, sir.
You just say in orderly way. Either you start from the prostate, membranous, bulbar, or
Yes, sir.
penile, or go on the reverse side. What are all the urethras which you could palpate?
The penile urethra and bulbar urethra, sir.
Yeah. Among this, as you said, bulbar urethra is the most important one. Why bulbar urethra is most important one to examine?
So because the diameter of the urethra is very short, so there are the chances of stricture in bulbar urethra, sir.
Where do you examine the bulbar urethra?
So at the
Where do you
root
examine?
of at the root of the scrotum, sir.
You have to lift up the scrotum. You have to
Root of
lift up this.
penis. Root of
Root of the
penis.
penis. So you have not done the test, ma. Absolutely, you have not done
You
the
have to
test.
lift. You have to lift up the scrotum.
And the perineal
And
region,
then
you have to
perineal
palpate that.
region where you have to feel. That is where you look for the bulbar urethra. Now, sir is asking the diameter.
Is it the bulbar urethra is the narrowest part
the-
of urethra?
Sir, membranous urethra is the
No.
narrowest part of the
No.
Narrowest part of the urethra is external urethral
External
meatus.
urethral meatus.
The narrowest
That is
part of the
correct.
urethra is external urethral meatus. Starting, you have to check first whether the patient is having phimosis or not. If the
Yes, sir.
patient is not having phimosis, check for the external urethral meatus. Then check for the penile urethra. Then check for the bulbar urethra. And bulbar urethra is more prone for stricture because of certain reasons. One is it is very prone for injury. Something when the boys start learning bicycle, they commonly get injured while crossing over their legs or falling from the cycle. And the another point is the infection, gonococcal infection is very commonly affects the bulbar urethra, and at a maximum it may produce water can perineum, multiple fistulas, and on healing it produces picture. So even though we may be able to palpate the penile urethra, most of the times the stricture is present in the bulbar urethra. So
Yes, sir.
all these things has to be examined. And one another question is regarding the perrectal examination. Can you go to that slide? See, you said perrectal examination is normal. What are all the precautions you are supposed to do, or what is the contraindication of perrectal examination in a patient?
In case of fissure or in high anal tone, sir.
How will you find out a fissure?
By inspection of the anal canal, sir.
Yes, whenever you, before doing a perrectal examination, you are supposed to inspect the region first. You are supposed to inspect the region. What will you find if the patient is having an acute anal fissure? What is the finding you will be able to see? What
They
is
will be,
sentinel pile?
sir, the hypertrophy of the skin, sir.
The hood of a skin that covers the fissure is called as sentinel pile. It is not a real pile. It is not a real pile mass. When you see a sentinel pile, then you should be very cautious. You have to
Yes.
check whether the patient is having fissure, ask the history whether the patient is having severe pain following defecation. If at all the patient says this kind of history, you should try avoid doing a perrectal examination because it may cause very severe pain. Okay.
Yes, sir.
And
Yes, sir.
whenever you come across this kind of patients, you should also ask about history of hypothyroidism in these patients. Hypothyroid patients may have constipation and fissure is common among them. And when there is no fissure, you can do a perrectal examination. What are all the things you may be able to elicit by doing a perrectal examination?
Sir, I will look for the stool consistency if there is any constipation or not. On the interior side, I will go for the palpation of the prostate, sir, and if I will be able to palpate the interior edge of the prostate, sir.
See, you may be able to palpate the prostate. Apart from that, if at all the patient is having any past history of surgery for hemorrhoids and all, the patient may have stenosis, anal stenosis,
Yes, sir.
which could be appreciated by doing a perrectal examination. Apart
Yes, sir.
from that, you may be also able to find out any malignancy, circumferential growth, which
Yes, sir.
itself may cause difficulty in defecation. This anal
Yes, sir.
stenosis as well as the circumferential growth may cause difficulty in defecation. So these are all the points. They should also be taken into care when you do a perrectal examination. Just you cannot put your finger and ask the patient to lying down. You must inspect, check whether the patient is having any fissure or not. Yes,
Yes,
that's
sir.
all from my side, sir.
Okay, Dr. Deepti, I
Yes,
think let's come to your diagnosis now.
Yes. My diagnosis is right incomplete indirect inguinal hernia with antrocoel as its content without any features of any complication at present without any comorbidity.
So in an indirect hernia, you
Yes,
have
sir.
the sac coming out from the coming out through the internal ring out through the external ring,
Yes, sir.
isn't it? Right.
Yes,
So why don't
sir.
you call it a congenital hernia? How is it different from a congenital hernia?
Sir, in
Congenital
case
hernia
of
also does. Yeah, go on.
in case of congenital hernia, mostly the swelling will be inguinoscrotal because it occurred due to the presence of patent process vaginalis. So the swelling will be inguinoscrotal in region, and it will.
Is it?
In your presentation itself, you have started with the inguinoscrotal 7 into 8 centimeter. Now you are saying that it will not be, it is only inguinal. And do you think
Let's get your facts correct.
Congenital hernia will not be always inguinoscrotal?
Is your hernia inguinoscrotal or is it inguinal? Let's get your facts correct.
Sir, it is only inguinal.
Okay. So you think a congenital will be an inguinoscrotal and then in adult it is only in the inguinal region. How is it different from a congenital hernia? Why don't you call this a congenital hernia? You've got a sac coming out from the
Yes,
internal
sir.
ring out to the external ring. You've got contents coming out. Why don't you call it a congenital hernia? Because congenital hernia is present since birth.
Yes, sir.
This fellow is coming after some time,
Yes,
isn't
sir.
it?
Yes.
So this is the theory, this Hamilton-Russell theory. What does it say? Have you heard of it, Hamilton-Russell theory? It says that all inguinal hernias, indirect inguinal hernias, are basically congenital hernias. It is just that they present later on because of
Yes,
any
sir.
precipitating factor.
Yes.
Yeah? Okay. So how will you manage?
So the management will will be the operative management, sir, because in inguinal hernia there are the chances of the complications. So we will go for the
No,
operative
hang on,
management.
hang on. What will you tell the patient? How will you counsel the patient?
Sir, I will say the patient, I will tell to the patient that the swelling is of this size for now, but it may increase eventually, and it may also undergo into complications. So it is better to go for the operative management, sir.
So, what complications will you tell him?
Sir, it can convert into the irreducible hernia, which can later convert into the obstruction or strangulation, sir.
So it has to go first into irreducible and then obstruction. It can't go into obstruction straight away.
So it can go into obstruction straight away, sir.
Okay, let's start the complications.
What is the difference in incarceration and obstruction?
Sir, in case of obstruction, there will be the intestinal obstruction. The lumen of the intestine is obstructed, and in case of incarcerated, the content is large intestine, and it is
Again, the
loaded with
lumen-
feces.
There again, the lumen is obstructed.
Yes, sir, but it is due to the feces, sir, not due to the narrow neck or due to the adhesion, sir. The cause is due to the feces, sir. So that's why it is not reduced, sir. But there are no signs of
Any
obstruction.
luminal cause is incarceration. Okay.
Yes, sir.
Extra luminal causes can be
Obstruction, sir. Yes, sir.
okay. So one is obstruction. Other you said incarceration.
Yes, sir.
What else?
Strangulation, sir.
Strangulation. What else?
Inflammation of the sex, sir.
Inflammation of the.
Inflammation of the sac.
Okay. Suppose the patient says, "I don't want any surgery."
Yes, sir.
Right. Then what will you tell him?
Sir, I will ask the patient for the regular follow-up and to look for the size of the swelling. I will explain the patient about the sign and symptoms of obstruction and strangulation, and I will advise the patient
No, you can't send him home like that. You have to convince him that he needs surgery, right? That you have to tell him that there's nothing called conservative management.
Yes, sir.
It's either surgery or no surgery, right?
Yes, sir.
The only treatment is surgery for this.
Yes, sir.
Okay, what kind of surgery will you do?
Sir, we can go for open surgery or the laparoscopic surgery, sir. We will counsel for the patient, and the laparoscopic surgery will be dependent on the expertise and the instruments available, sir. So I will give the patient option of the open surgeries and laparoscopic surgeries. Among the open surgeries, the most preferred one is the
Hang on. We're not asking you most preferred. You say either open or laparoscopic. Patient says he wants lap. Now
Yes,
what
sir.
will you do?
Sir, I can go for the TEP or TAP, sir.
How many TEPs have you done?
Not any, sir.
So how will you do it? Do you tell him? How will you advise him that I'll do TEP? So what will you do now? You've told him that I'll do TEP. Later on, you say, I don't know TEP. Go to some other doctor. Do that. Will you do that? You'll call someone who knows. You'll seek help. That's what I'm saying. So that if you're stuck, if you don't know something, always call for help.
Yes,
They
sir.
will do TP. Get your friend who knows.
Yes, sir.
Okay. Which open surgeries which you prefer? Would you prefer?
Sir, Lycostin tension-free repair, sir.
Okay. Why do you prefer this surgery over other open surgeries?
Sir, other open surgeries will be the tissue repair, sir. And in case of tissue repair, sir, there are the chances of recurrence because
all other surgeries are tissue repair.
No, sir. The one of the surgery is tissue repair, sir.
Okay.
You are
The surgery.
You are doing the surgery. You are opened up. What are the structures you will be interested to know?
Sir, on opening the external oblique aponeurosis, first I will safeguard the ilioinguinal nerve.
Can you trace the ilioinguinal nerve from where it comes?
Sir?
Ilioinguinal nerve comes from where and goes where?
Sir, it comes from below the anterior suprailiac spine and goes
No.
into the inguinal canal.
Always when the nerve, you must ask the starting point and ending point. From where it starts. Ilioinguinal nerve belongs to which group and from where it comes?
So from the lumbar group, it is L1 and L2 nerve root, sir. It will start from there, sir, and it will
Lumbar
come from the
lumbar plexus. No?
yes, sir, lumbar plexus, sir.
Good. Then it supplies what?
Sir, it will supply the muscles of the anti-abdominal wall, and it gives the sensory supply to the medial part of the inguinal ligament and to the upper adjacent to the femur tuber.
Is it comes through the deep inguinal ring?
Yes, sir. It comes to the deep. It doesn't come to the deep inguinal ring, sir.
Okay. Then how it comes?
Sir, it comes from behind the anterior suprailiac spine and pierces the transverse abdominis muscle and run in between the internal oblique and transverse abdominis muscle, sir.
Good. So it doesn't come from the deep inguinal ring. It is only coming by the piercing there.
Yes.
So you see the vast difference also. Can you trace the vast difference where it starts, where it ends?
No, sir. I will not trace the distal end of.
No, I'm asking you a question. From where it comes, starts, and where it ends.
Sir, it starts from the caudal end of the epididymis, sir.
Very good.
It's
Trace the
from the
pathway.
Yes.
Trace its pathway.
Yes, sir. It starts from the caudal end of the epididymis and goes above the goes into the superficial inguinal ring, traverses the inguinal canal, and then goes into the deep inguinal ring, sir.
That's all. Ends there. It goes to the deep inguinal where?
Then goes into the mixes with the seminal vesicles, and then goes into the urethra, sir.
Very good. So you must know all the structures and where it starts and where it ends and what are the structures it's coming, including artery, including vein, and you must know that.
Yes.
Okay, Dr. Deepti.
Yes, sir.
Quick question. I think we're just running out short of time. What are the complications of Lichtenstein repair?
Sir, there will be the seroma formation or hematoma formation. There will be a surgical site infection. It may be superficial or deep. There are the chances of the recurrence of the inguinal hernia. There will be the ischemic orchitis or the testicular atrophy, sir, later on. And other cases are the hematoma and bleeding, sir.
Okay.
Where do you get ischemic orchitis?
Yes, sir. And
Where do you
testicular
get
atrophy.
no? Where do you get ischemic orchitis?
Sir, because of the thrombosis of the pampiniform plexus, there will be ischemic orchitis, sir.
So vein is thrombus, you will get an ischemia.
Yes, sir. The main cause is the thrombosis of pampiniform plexus, sir.
Okay. Then why it produces ischemia? Ischemia is due to arterial problem, no?
Yes, sir.
Pampiniform is a venous problem.
Yes, sir.
So where do you get ischemic orchitis? So which? No, there must be some artery must be involved.
Yes.
So is it?
Okay, tell us what are the arteries to the testes? Tell us the arteries to the testes.
Sir, testicular artery to the vas deferens, sir.
And testicular artery is coming from?
Directly from the aorta, sir.
Both sides.
Sir, on the right side, it is directly from the aorta, sir.
Left side.
On the left side, it will be from the left renal vein, sir. From the left renal artery, sir.
Hey, be carefully. Just because I am asking, don't change. So both testicular artery, both sides comes from aorta only. It's only the vein you have a change difference. You should not get confused.
Yes, sir.
Then each word which you are saying is important. When you are saying ischemic orchitis, you must know which. Even if the testicular artery is cut off, the testis can get the blood supply from artery to vas, you said.
Yes, sir.
So, but if it's the vein is complained, what is how it is goes for changes?
So there will be the painful and tender and tense scrotum, sir, in this case.
No, you are confused, Sima. Only when you have a arterial torsion, yes. But venous, it's not ischemia, it's a congestion.
Yes, sir.
Okay. So what you are planning for this case is Lichtenstein repair.
Yes, sir. Lichtenstein repair, sir.
So if you don't have a mesh, you have any other alternative?
For the if I don't have a mesh, then I will go for the suturing of for the tissue repair. So then I can go.
Which is your favorite tissue repair?
Shoulder repair, sir.
You know the steps?
Yes, sir.
Okay. Any other repair?
Sir, basini repair and shoulder repair, sir.
So Indian, another repair which has been very well documented and put in the Bailey and Love also.
Sir, McFaddy or Cooper's repair, sir.
No, Indian, not Indian surgeon.
I don't know, sir.
Anything you do with the external oblique?
Sir, external oblique in what case?
No, okay. For hernia repair, you can use
Yes,
the
sir.
external oblique for repair.
Yes,
The
sir.
Sarada technique?
Yes, sir.
Okay.
In that we will use the flap of external oblique. Sir.
If the patient
Hello.
is having a chronic cough and this hernia,
Yes, sir.
anything else you will do for the patient? He has an emphysema.
Sir, I will ask for the history of the smoking in that patient. If the patient is a smoker, I will ask the patient to stop smoking and for the abstinence, sir. And after the patient start the smoking, then
What is the role of smoking here?
sir, it causes the increase in smoking causes the coughing and causes increase in abdominal pressure, and smoking also causes the weakness of the abdominal muscles, sir.
Oh, ma, how the smoking causes weakness? How the smoke causes weakness? It has to do something. Now, all the theories are, Sagai sir has said, all are congenital. Only your reason, something will precipitate it, occurred it.
Yes, sir.
So something basic defect will be there. What
Yes,
is the
sir.
basic defect there, which smoking will aggravate? What is the normal collagen in the collagen content? You know any role of smoking on a collagen synthesis?
So it decreases the collagen synthesis, sir. Smoking decreases collagen synthesis, sir.
No. There are types collagen, types 1 and type 3. That combination is 80 to 20%. So type
Yes, sir.
1 is reduced and type 3 is increasing. So main reason is collagen. Even if you cough, it is not the pure cough. All of us are coughing. We don't get a hernia. There are a lot of protective mechanisms. But people
Yes,
who cough, people who smoke gets a hernia because of the collagen deficiency, which the hernial sheet is also, hernial sac, all is going to be getting weakened. Otherwise, it is not the reason. So you must know. So how you are going to treat congenitally, you must test, which you will test to analyze the collagen power.
I don't
Any, you know anything about elastase, alpha-1 trypsin deficiency?
Yes, sir.
So all that will tell you about the collagen.
Yes.
So, Dr. Jailal, I'll ask her 1 or 2 questions.
Please, sir. Please, sir.
Dr. Deepti,
Yes, sir.
where do you ligate the sac?
Sir, as near as possible to the deep ring, sir.
What is it called as?
High ligation of the sex, sir.
What is the reason?
Sir, to prevent the recurrence, sir, in that case.
How do you identify that area?
Sir, I will palpate for the inferior epigastric artery. Deep ring will be inferior epigastric artery will be medial to the deep ring, sir. So
More than palpation, you can see. Understand? You can see the pulsations. And
yes, sir. And to see for the preperitoneal fat, sir.
what do you understand by lateralization of the cord?
Lateralization of the cord is done to strengthen the deep ring, sir.
Narrowing. So by
Yes, sir, narrowing.
placing
Yes,
the cord laterally, widen the ring, especially you have to narrow. What is
Yes,
that structure which you repair there?
Sir,
Because-
iliopubic.
No.
Iliopubic.
No. I think we are talking open method. So what is that defect that which you are going to narrow? By
Fascia transversalis, sir.
internal oblique and that fascia transverse, that area. So
Yes,
where
sir.
the deep ring is emerging out, you have to put some sutures. That's called
Yes,
a
sir.
lital. You know that
Yes,
lital.
yes, sir.
Right?
Yes.
So that is the one of the important thing. If there is an obstructed hernia with suspicion
Yes, sir.
of gangrene, what repair you will do?
Sir, in case of obstruction hernia, I will not look for the neck of the sac. I will first open the contents to evacuate the fluid that is present because it is toxic and it may go through the neck into the peritoneal cavity and that will be the toxic, sir.
No. Yeah, correct. What I asked you is what is the ultimate final repair you do? If you are asked this question, yes.
Sir, if the bowel are not gangrenous, I may go for the mesh placement, sir. If the bowel is gangrenous, then I will go for the tissue repair, sir, in that case.
Can still consider bassini repair, even though it may not have the best results or something like that. But with the emergency situation, because
Yes, sir.
you mentioned about the shoulders repair. Have you seen one? Do you have any idea how to do it?
I have just read it. I have not seen it, sir.
So which is easy to do? If you are not
Basically is
comfortable with the
basically is
disorder,
easy to do, sir.
so that's not very difficult.
Yes, sir.
Not very difficult. Only criticism. What is the basic criticism of bassini repair? It has stood the test of time for more than 100 years. Eduardo Bassini. Yes. What is the yes.
Sir, in case of bassini repair, the conjoint tendon is sutured with the reflected part of the inguinal ligament, sir,
So it
to
is
strengthen the posterior wall, sir.
so what is the word which is normally used more than suturing is
Double
approximation.
breasting.
No. That is different. What you want? Approximation. So the
Yes,
problem of force, always tension.
Yes,
So
sir.
if you are comfortable, you can even do one darning. You heard of darning? Darning.
Yes, sir.
So if
Sir,
there is
in darning, we have to take the non-absorbable sutures in different planes, sir.
something like you are creating an artificial mesh-like thing. See, all these
Yes,
are,
sir.
I'm not trying to say the best solution, but in your situation where you are suddenly confronted with this situation, don't try to make incision of the transverse fascia and all this, shoulders and all, which you are not comfortable. Which you are comfortable,
Yes,
still you can consider. Yes, with a rate of some recurrence. Okay.
Yes, sir.
That's all from my side. Thank you, sir.
No, in the litis hernia, there is the ring. Which side you will close? Medial to lateral or lateral to medial?
In what, sir?
The deep ring narrowing.
Yes, sir.
There is a lateral end, medial end.
Yes, sir.
From which side you will narrow?
I will narrow it on the medial side, sir.
Okay. So in continuity of the switches which you are doing, that you have to take that narrow. And where do you take the first stitch in the when you are fixing
Sir,
the mesh?
At the pubic tubercle, sir.
Pubic tubercle is a large area. It has a periosteum, it has a bone, it has a lot of stretches going, big and ligaments going there. Which one you
Sir,
take?
above the face, above the pubic tubercle with the fascia, sir, not with the periosteum or bone, sir.
So what will happen if you take a periosteum?
Sir, it will lead to osteitis and chronic pain, sir.
It's one possibility. So you don't take in the older way, we don't take the bite on the periosteum. What are the other derivatives of the transversalis fascia?
Sir, iliopubic tract is a derivative of transversalis fascia and fascia lata, sir.
Any other ligament? What is Cooper's ligament?
Cooper's ligament is an extension of inguinal ligament, sir, and run along the pecten pubis, sir.
Cooper's ligament is not a ligament. Even both the Gimber knots and the Cooper's ligament are the part of the transversalis fascia. It is a reflected part of the transversalis fascia. Old anatomists will say Gimber knots, but not Cooper's. Lacunar ligament will be the part of the inguinal ligament. But actually, with anatomy, surgeon feel it is also a part of the transversalis fascia.
Okay, sir.
Suppose the patient comes with a recurrence.
Yes, sir.
So what you will do? If it comes with the which part, medial part or lateral, where do you get a recurrence commonly?
Sir, the most common recurrence will be on the medial side, because on the medial side, the internal oblique will be inserted higher up in the pubic tubercle, and there will be no muscle there, and there will be no conjoint tendon on the medial side, sir. So that is the most common site of recurrence, sir. Medial side.
How do you prevent it?
Yes, sir.
How do you prevent it? Or what
Sir,
precautions you take to prevent
sir,
it?
when we place the mesh in the hernia, we will place it 2 centimeter beyond the pubic tubercle, sir, to strengthen the wall, sir.
Which mesh you prefer?
So I will prefer the lightweight macroporous mesh.
Why do you prefer a macroporous? What do you
Sir,
mean by
because it.
macroporous?
Yes, sir.
What do you mean by macroporous? When you say it is a macroporous mesh,
Sir. The pores will be there, sir.
no, what is the purpose of using mesh there?
Sir, in macroporous mesh, there will be growth of the tissue in between the pores, and that will strengthen the mesh there, sir.
In a micropore also it will grow.
Sir, but in microporous, there will be the more chances of shrinkage in that, sir.
That's not the reason, but okay, whatever the choice you choose. What is the size of the mesh you use?
Sir, the size mostly will be 7 by 15 or 12 by 15. So depending on the defect, sir.
You get a 7 into 15 mesh.
Yes, sir.
You're sure? What mesh you have used when you have done a surgery?
So soft
What's
choline
the-
mesh, sir.
No, what is the size?
So mostly 12 by 15 or
Hello, sir.
No, that means you are not looked into that. There is a 15 into 15 mesh. If you say that you cut it into 2, then it is 7.5 into 15. Then again you have to cut it. Otherwise, the mesh, what is pre-made mesh is available.
yes, sir.
What is it? Okay. Pre-made mesh, already available mesh size.
Yes, sir. There. It
What
is
is the
10
mesh?
by 10 by 15 mesh, sir.
Go and check, what is the mesh available with you before using the mesh. And what switcher
Sir,
material you use to
Kanagvel
Sir,
sir
we are
has
using-
asked to close.
Vicryl, sir. Vicryl 20, sir.
Jailal sir.
fixing cycle? Yeah.
Yes, sir. We are fixing the mesh with the Vicryl, sir.
Jailal sir, Kanagvel sir
Huh?
has
Hello,
asked
sir.
to. Can we close it? Go for the next
Close
case,
it.
sir.
Yes.
Jailal sir, can we, sir?
Yes, please.
Yes,
go
sir.
ahead.
Yes, sir.
Rajiv sir,
Sir, already,
Karnal,
already texted on the.
The only
Group.
thing, you go back to the operation theater, please see how the hernia surgery is being done. And if you are saying something wrong on the mesh repair and putting a vicryl stitch, all that, be careful on that and what you are talking. Similarly, examination of the case also, please, little more care you must put.
Yes, sir.
Well done, Deepthi. Nice presentation.
Nice
Yes,
presentation.
yes. Well done, ma. You have
Keep it up.
anything to ask the faculty, ma? Any doubts you have?
No, sir.
Okay. Can we go to the next case? You can stop. Dr.
sir.
Singh Dr. Kanwar Pratap Singh from
Hello, sir.
Jorhat
Good
Medical College, Assam. You
Am
can
I
start
audible, sir?
sharing. Yeah, you're audible. Kindly share your screen. Dipti, you can stay back for the next case if you are interested.
Yes.
Let Kanwar share your screen, please.
Yes.
Yeah, make it slideshow.
Good evening, respected faculties. Myself, Dr. Kulan Pratap Singh, second year PGT from Jorhat Medical College and Hospital, under the guidance of Dr. N.N. Ganguly, as professor and HOD, presenting a case of carcinoma oral cavity. My patient, Mr. X, 35-year male, residence hails from Lakhimpur, Assam, Hindu by religion, married, daily wage laborer by occupation, received no formal education, examined by me on date 23rd of August 23, presented with LMCH OPD with chief complaint of ulcer over left side of the tongue for 2 months. History of presenting illness. My patient was apparently well 2 months back when he noticed an ulcer in the left side of the tongue. It was insidious in onset and was noticed while brushing his teeth. It was gradually progressed from initial size of 1 into 0.5 centimeter to the present size of 3 into 2 centimeters. No other ulcer noted in any other part of the oral cavity. It was not associated with pain. There was no history of difficulty in chewing, swallowing, or speech articulation. No history of any swelling in neck or earache. No history of fever. No history of weight loss or loss of appetite. No history of sharp tooth or any associated trauma. Was not associated with excessive salivation or decreased mouth opening. Coming to past history, there was no history of similar illness in past, no history of diabetes mellitus, hypertension, asthma, tuberculosis, no history of any surgery or any dental procedures in the past. And personal history, he consumes average non-veg assemblage diet 3 times a day consisting of rice, meat, pulses, and vegetables. History of tobacco chewing for approximately 5 years. A local brand mixed with slate lime and ketchup. Consumed alcohol for 5 years on an average of 500 ml of local alcohol per week. No history of smoking or high-risk sexual behavior or any form of drug abuse. Family history, no history of similar illness in family. No history of diabetes mellitus, hypertension, and asthma in family. Socioeconomics, he resides in Kacha house with a 3 number of rooms with adequate lighting. Separation, source of drinking water is borewell and is not boiled. Sanitary toilet present. Family income is 7,000 rupees per month. Drug history, no history of any long-term intake of any medications. Allergy history, non-allergic to any ingested or inhaled substance till date. And BCG scar immunization history, BCG scar was present and received 2 doses of COVID vaccine. Coming to general physical examination.
Dr.
Pratap,
Yes, sir.
Let's go to your first slide. So left side of the tongue since 2 months, 35-year male. Okay, next slide.
go to the first slide.
Yes.
What sort of pain did you ask for?
Sir, whether it was I asked for whether he was taking any food, then it was present, pain was present or no, or
Where?
any
President ulcer.
over the ulcer, sir.
Any other pain would you ask?
Referred to otalgia, sir. I have asked for pain in ear and whether burning sensation on taking lot of spicy food. There was no such history, sir.
Okay. Next slide.
Why there is
Okay,
air?
Yes, sir.
Seeing why there is a air pain?
So here
Why
it is
pain
due
will
to
be?
so because the tongue is general sensation of anterior two-thirds of the tongue is supplied by lingual nerve, which release in the otic ganglion, and from that auriculotemporal nerve also supply also goes, and these two communicate. These two are the branches of mandibular nerve. So the pain is referred to the ear, sir, mainly in the ear canal, sir, anterior two-thirds of the tongue.
Why there is excessive salivation in case of CA, tongue or
So
oral cavity?
So excessive salivation may be due to chronic irritation, followed by reactionary parasympathetic stimulation, salivation, or it could be due to inability to swallow, difficulty
Swallow.
in swallowing.
Hmm.
so any other cause of pain? When he said is you get in the tooth earache. Any other cause? Any other pain? Can you? Yeah. How? When will it also be painful?
So if it involves the nerves or muscles, muscle involvement of muscle or height and
Is it?
hypoglossal nerves and
No,
lingual nerves.
No. When it gets infected. When it gets infected, and also is
Yes, sir.
infected.
It is. Yes,
Then
sir.
you get
Also in secondary infections, sir.
Okay. You've taken his. What about his dental? Any tooth extraction?
No, sir. There was no history of any tooth extraction or any dental procedures in the past. Sir.
Why is that important?
So
Why is that
because if there could be sharp tooth, which could lead to traumatic dental
Sharp tooth is
ulceration.
different. Sharp tooth is different. Sharp tooth is different. That is because causing trauma. Any other importance of tooth extraction or loosening of the tooth?
So it's could give us clue that it could arise from alveoli and alveolus region, sir.
Right. So it tells you about the
gingival primary.
underlying disease. It tells you
Yes,
about
sir.
the underlying disease. Okay. Okay. What about? Have you asked about protrusion of the tongue?
Yes, sir. It is inspection finding hypothesis.
Okay. So, is there any problem in protrusion of the tongue?
No, sir. There was no problem in protrusion, sir.
So why would you ask for that?
So because floor of mouth involvement will be there and it could cause difficulty in protrusion of the tongue, sir.
So which muscle would be involved in difficulty in protrusion of the tongue?
So genioglossus will be involved, sir.
Very good. It's the only muscle for protrusion of the tongue. Any deviation of the tongue? Did you ask for any deviation of the tongue?
Yes, sir. There was no deviation of tongue, sir. Because the ulcer was superficial, which will be seen in those clinical pictures, sir. And
you asked about mouth opening. So
yes, sir,
how do you decide about mouth opening, decreased mouth opening?
So mouth opening was adequate. Patient was able inter-incisor distance on when I measured it was 4 centimeters.
That's the examination. Karunendra, that's the examination. It doesn't come in your history usually, unless he says that I have difficulty in eating. Right? That's examination. Okay. So. Okay, let's go to the next slide. Okay, next. Anything to do with his sexual behavior?
Sir, because high sexual behavior because of could be due to HPV associated oral cavity cancers. is usually rare in oral cavity, but it is also a risk factor. That's why I have included whether he has a
So
history of any sexual.
how does HPV affect malignancy here?
So on the basis of pathogenesis, sir, or clinical findings. Sir.
No, okay. You tell me, is the malignancy associated with HPV good or bad? Prognosis is good or bad?
Prognosis is good, sir, but clinical picture, lymph node involvement is
Why is it good?
large lymph nodes are there, but overall prognosis is better than HPV negative.
Why is better in cases of CA oral cavity associated HPV?
Yes, sir.
Why is CA oral cavity associated with HPV having a better prognosis?
Sorry.
One is that this usually happens in younger patients, right? It happens in younger patients, HPV associated.
Yes.
Also, they may not be associated with tobacco. The ones associated with tobacco have a much poorer prognosis because of the changes they produce, right?
Yes. Yes.
And so these are the two reasons. Otherwise, we don't know exactly. Right. Next slide.
How tobacco causes malignancy?
So tobacco causes it causes direct DNA damage, and it also increases the solubility. Solubility over the overall solubility of the cells, so increases, and it enters and forms DNA adducts, leading to DNA damage.
You have not asked any history regarding any lesions or ulceration or any white patch in oral cavity or red patch. Have you asked? Did you
Yes,
ask?
sir, I have asked. Yes, sir, I have asked, sir. There was no history of any red or white patch or any difficulty in opening of mouth, which could suggest some mucosal fibrosis.
What is leukoplakia?
So it is the whitish coating over the oral cavity or the tongue, which could not be clinically or pathologically explained by any other pathology.
And what is erythroplakia?
Red velvety patch over the oral cavity and the oral cavity mucosa and over the tongue, which could not be explained clinically or pathologically any other subtypes.
Which is more dangerous?
So
Leukoplakia or
erythroplakia has more chance of malignant conformation than leukoplakia.
proceed.
So now coming to general physical examination. Patient was conscious, well-oriented to time, place, and person, average weight and well-nourished, weights range 62 kgs, height 170 centimeter, BMI of 21.45 kg square, PCOG performance status was 0, pulse rate is 78 per minute, regular, normal in volume, condition of vessel wall was normal, no radial or radiofemoral delay, and peripheral pulses were palpable. BP 130 by 80 mm of mercury, measured in right arm in supine position, temperature 98.6 degree Fahrenheit, respiratory rate 18 breaths per minute, regular, GCS was equal V5 M6, was maintaining technical of choice. There was no pallor, icterus, cyanosis, or dehydration, no dilated neck veins, no clubbing or colonesia, no edema, or no lymphadenopathy. Local examination or inspection, facial symmetry was maintained, mouth opening was adequate, no missing or loose or sharp teeth was present, orodental hygiene fair with no halitosis, some nicotinic staining of teeth were present, and ulcer was noted in left lateral anterior tongue of size approximately 3 into 2 centimeter, which is oval in size, the regular margin, averted edge, mainly located on the ventral surface of tongue, 1.5 centimeter from the tip and 3 centimeter from the circumvallate papilla. The ulcer is embedded with the adjacent mucosa overlying the floor of mouth. However, dorsal surface of the tongue appears to be free. There was no visible bleed or slough overlaying the ulcer. Tongue protrusion is unrestricted. No erythroplakia, leukoplakia, or premalignant lesions noted. The rest of the oral subsides and neck appear normal. This is the clinical image, sir. Through local exam palpation, sir, respective findings were confirmed. Mouth opening was 4 centimeter, and ulcer noted in left lateral anterior tongue of size 3 to 2 centimeter, oval in shape, irregular margin, averted as mainly located on ventral surface of tongue, 1.5 centimeter from tip to 3 centimeter from circumvallate papillate, with induration and hard base, and was non-tender. On biodigital examination, induration was approximately 0.5 centimeter thick. And the ulcer is mobile over underlying muscle of tongue and floor of mouth and doesn't bleed on touch. There was no sharp or loose taste finding. Cervical lymph nodes were not palpable, and indirect laryngoscopy was within normal limits. And the systemic examination was normal finding over there. Systemic examination, sir. And summary of my case: 32-year male, daily wage worker, from tobacco chewer, with history of alcohol intake, presented with 2 months history of non-healing painless progressive ulcer in left side of tongue. Oral cavity shows ulcer in left lateral anterior tongue of size 3 into 2 centimeters, which is oval in shape, irregular margin, averted edge is mainly located on the ventral surface of tongue, 1.5 centimeter from the tip and 3 centimeter from the circumvallate papillae, with indurated base with non-palpable cervical lymph nodes. My provisional diagnosis is malignant ulcer of left lateral border of anterior tongue. Clinically stage T2 M0 and J.
What about mouth opening? You are not mentioned about mouth opening.
So mouth opening was adequate, sir, 4 centimeter. There was no trespass, sir.
What is normal mouth opening or grading?
So just more than 3.5 centimeter is adequate mouth opening, sir, and less than 3 up to 3 to 3.5 centimeter is known as grade 1 trespass. Grade 2 trespass is 2 to 3 centimeter mouth opening, and less than 2 centimeters is grade 3 trespass, sir. And it is measured between inter incisor distance.
Is the commonest site of the tongue malignancy?
Most common sites in India is buccal mucosa, but in western
I'm asking about tongue.
Yes, sir.
Tongue.
Overall, in tongue, sir, most common site is lateral border of the anterior 2/3 of the tongue.
Okay.
Followed by posterior 1/3 of the tongue.
Why is that the lateral border is more common?
So it is because of the habit of taking betel quid in the lateral border of the tongue.
So they keep it under the tongue, or they keep it in the gingival fossa, in the buccal mucosa?
Both the cases are there, but and also due to sharp dentures, lateral border is more prone for some malignant transformation.
What happens is that the floor of the mouth and the base of the mouth is always bathed with the saliva, right? So the lateral margin and the floor of the mouth is always bathed with the saliva, and this constant exposure to carcinogens makes it a common site.
Yes.
Okay. Did you talk about any halitosis?
No, sir, there was no halitosis.
You mentioned it, have you?
Yes, sir. Oral hygiene was also maintained, sir. erosion halitosis, sir.
Okay. So why is halitosis common? Why is halitosis common?
So it is due to sir, overlying ulceration in presence of necrosis may result in halitosis, sir. And due to malignant cells, they produce excess butyrates and mercaptans.
No, more common is that these people, this guy has a good oral dental hygiene, but most of these don't have, right? So there is associated caries tooth, and then there's breakdown of the cells and there's secondary infection. So they all lead to halitosis. What's the role of alcohol? You said, okay, we've spoken about tobacco. Tobacco, because of all that, all those carcinogens. What about alcohol?
So because alcohol also gets converted into acetaldehyde, sir, in the oral cavity by
Alcohol
the
gets converted
commensals.
Sorry, alcohol gets converted into?
Acetaldehyde, sir, acetaldehyde. And
in the mouth.
Also great
in the mouth.
in the mouth.
In the mouth.
Yes, sir. Some amount of commensals convert, very little amount of sir, in the oral cavity, and it leads.
Is it? Where have we got this from? Look, alcohol is basically a solvent. It increases the solubility of the carcinogens. It's an irritant. It's a promoter, right? And it does suppress the efficiency of DNA repair when it is exposed to nitrogen. It doesn't convert itself into nitrogen. You get it? So it's just acting like a solvent, like a promoter, like an irritant. Okay. Okay. What does this person work as?
Yes, sir. He is a daily wage laborer, sir.
Laborer. So, what are the other factors which can cause oral malignancy other than smoking and
so it could be, sir, due to genetic factors, presence of sir pre-malignant precancerous
which genetic factor?
So in P53 gene mutation hereditary like Leaf Romano syndrome or DNA damage, DNA repair defects like
okay, that's fine. What are the other ones?
And ataxia telangiectasia, Down syndrome, Fanconi anemia. And
Yeah, we've got that.
Okay.
Anything else?
And so presence of in rare cases like syphilitic.
What about diet? What about diet?
Diet is non-vegetarian diet also has a significant red meat.
Red meat.
And predisposing factors.
Dietary deficiencies, vitamin deficiencies, right? Yes. Wood dust exposure, they all cause.
Yes.
So, what are the pre-malignant conditions?
So, pre-malignant conditions are erythroplakia and oral cavity, leukoplakia, and chronic hyperplastic candidiasis. And pre-cancerous conditions are sideroblastic dyspnea.
So, what's the difference between pre-malignant and pre-cancerous?
So, pre-cancerous lesions are altered morphology of the tissues, which will predispose the same site for the cancer, sir. And pre-cancerous conditions are increase the risk of cancer in the individual, sir.
So those which cause dysplasia,
yes,
plastic conditions are pre-cancerous.
Yes.
Right? So what's the difference between leukoplakia and erythroplakia then?
So on morphologically, and they also, sir, it could be speckled. Erythroplakia could be speckled or homogeneous, sir. And
what's the difference?
Grossly, it appears erythroplakia appears red and velvety, and the leukoplakia is white patch, sir.
Okay, you finished the examination, have you?
Yes, sir.
You've given us your diagnosis. Okay, so why do you think it's a malignant ulcer?
So because it is painless, chronic, and
You said that
usually and non-healing, sir.
You-
And the chronic intake of sir irritants. Sir.
have you described also?
Smoke.
Let's go back to your description of the ulcer.
Yes, sir.
Let's go back to your description of the ulcer. Dorsal surface of the antisurfacing and the mucosa overlying the floor of the mouth. Okay.
Yes.
Could you make that larger? Could you make your picture larger? Okay. Next slide. So what this is lateral margin. Why do you say floor of? Is it involving the floor of the mouth?
No, sir. It's just abutting, sir. Also, just abutting, sir.
Okay. So what are the characteristics of a
floor.
malignant ulcer? What are the characteristics of a malignant ulcer?
So averted margins, sir, and with necrotic to center, and with induration around the ulcer.
So it's a hard ulcer with
Yes,
necrotic
sir.
everted margins
Harder.
and necrotic tissue in between. Right?
Yes.
Okay. Okay. So how do you proceed now?
So,
Lymph nodes, are
first
they?
of all, sir, incisional
No lymph nodes?
biopsy.
No, there are no lymph nodes.
Yes, sir, no lymph node were palpable, sir. So, I
Which lymph
will
nodes would you expect in this case? Which lymph nodes would you expect in this case?
level 1, 2, and 3 groups are usually involved, but most commonly involved lymph node is level
No, in
2
this
group
case,
of lymph node.
I'm not saying no. In this case, which lymph nodes would you expect?
1 to 3 group of lymph nodes, sir. Level 1, 2, and 3. Sir.
On one side,
And
only on the
with
left side? Only on the
Yes,
left side?
yes, sir. Yes, sir. Only on the left side, sir. So it's because
Why,
it has
why,
not
why,
crossed the
why can't
midline.
it be bilateral? Why
So
can't it be bilateral?
because the lymphatic supply of the midline of the tongue usually gets supply from both the sides of lymphatic, gives to both the sides of lymphatic. So contralateral spread is usually uncommon in case of lesion lateralized without crossing midline of floor of the nose.
No, okay, in tongue you can have bilateral. Why is it that in tongue you can have bilateral while in buccal mucosa it's usually not, it's usually unilateral?
So because tongue usually drains on the both the sides, mainly the midline part of the tongue.
So there's
Usually drains on
decussation.
the
Right? The tongue squeezes. When the tongue moves, it squeezes. So there's bilateral. Okay. So okay, how do you manage?
So usually, sir, I will perform, sir, because the lesion is small, sir. Without distorting the anatomy, I will go for contrast enhanced MRI from the base of the skull to the contrast enhanced MRI, sir. From the base of the skull
No.
till the yes, sir.
No, you straight go for MRI.
Yes, sir.
Investigation
Incisional
to confirm
biopsy,
the
sir.
diagnosis.
Sir, incisional biopsy of the lesion will be taken, sir. But sir, it
Incisional
could
biopsy
cause.
or
Yes, sir.
incisional biopsy or something else?
Sir, incisional biopsy, edge biopsy.
Huh?
Yes, sir, incisional biopsy will be taken. In case of small
Which
lesions less than incisional biopsy, sir. Yes, sir.
Karunendra, we are talking
What
of
is
your
disadvantage of incisional biopsy in this case?
So we will take the edge biopsy of So lesion is small, sir. We can also perform, sir, excisional biopsy, sir.
We're not talking about if we can. What will you do?
So incisional biopsy from the lesion. Yeah,
Okay, you
involving
take it from
both
the
the
margin.
normal.
Why do you take it from the margin?
Yes.
Why do you take
Yes,
it
sir,
from the margin?
because
Why not
central
from the
part
lesion?
will contain necrosis and necrosed cells, and we will take the biopsy to include both the normal and the altered necrosis.
No. You think your pathologist doesn't know what is normal, that you have to take something normal. You take it from the margin because there's maximum proliferation there. Maximum activity is at the margin, right? So, can you take a punch biopsy? What is important to the biopsy?
So punch biopsy can be taken in cases of, sir, proliferative lesions, sir. Since
Why
the
you can't take it here? You can't take it here, can you?
So the punch biopsy can be
Okay.
taken, sir, but it can
Let me put
cause,
it
sir,
another way. Karunendra, let me put it another way. Why do you want to take a biopsy? What do you want to see when you take a biopsy?
to look for, sir, malignant transformations in the mucosa, and to assess the depth of invasion of the cells, of the depth of invasion in the layers.
Right. Anything else? Which is very important
to
nowadays. AJCC.
to assess whether
Assess?
level differentiation of the cells.
Anything to do with depth?
So depth of invasion we will measure, we will see.
So it's not only that you want to see whether it's a squamous cell or usually it's a squamous cell carcinoma,
Yes, sir.
right?
Yes, sir.
So you
Yes,
have to
sir,
grade. You have to see whether it's a malignancy. You have to grade the malignancy, right? Grade of the tumor and depth of the tumor.
Yes. Yes.
These are things you have to look for. Okay. What do you mean by field cancerization? Do you have an idea? What is field cancerization?
So appearance of, sir, multiple synchronous lesions in the oral cavity or in the upper digestive tract.
Why is it that?
Two...
Why is it so common here?
Okay.
What is the difference between synchronous and metachronous?
So presence of, sir, malignancies within 6 months of the primary lesion is known as synchronous lesion, or appearance of malignancy after 6 months of the primary lesion is metachronous lesion.
Metachronous. Okay. Any other investigation you want to do apart from this? What is the role of pan endoscopy?
Pan endoscopy, sir, it will be useful in cases of when there is lymph node, there is unknown primaries there, or lymph node we found out to be clinically palpable lymph node, or in cases of unknown primaries, then we will perform, sir, esophagoscopy and nasopharynx, and also visualize the larynx to locate the site of primary lesions. It's basically done for, to detect any unknown primary lesion which is caused, which can cause cervical lymphadenopathy unexplained.
Any other X-ray you want to do?
So orthopantomogram can be done, sir, to look for mandibles, but CVCT would be better to, sir, mandible and involvement of the alveolar or any distal. Then and CVCT would be better to look for any bony involvement in the mandible or maxillary regions.
So how will you manage this case? What is staging of this case?
So it is stage 2 disease, but clinical stage T20, T2, N0, N0 comes under stage 2. So multidisciplinary approach will be followed, including surgical oncologists.
Wait,
And,
tell me what are the levels of lymph node?
there are total 7 levels of lymph node. Level 1 is divided into 1A and 1B, submental and submandibular group of lymph node. And the level 2, 3, and 4 are upper jugular, mid jugular, or lower jugular, respectively. Level 5 in the posterior triangle of the neck. And level 6 is brachial and pre-laryngeal group of lymph node. And level 7 is upper mediastinal lymph nodes.
What are different triangles of neck? How
So-
triangle is divided?
So triangles are digastric triangles, which is made of anterior belly of digastric and mandible, and it contains some mental salivary gland, and posterior triangles.
So how many components are there in entire triangle? It is divided into 4 parts.
Yes, sir. First part
Submental,
is
submandibular,
yeah,
carotid, and
and
muscular. This is the most important question. Okay. So what is your diagnosis here?
malignant lesion of the left lateral border of the tongue. Stage T2, N0, N0.
So how
What
you
do you mean by
manage?
T2? No, what is 2? You said stage 2? A.
T2, sir.
T2.
Yes, sir.
Show me your staging. What do you mean by T2?
So when the size of the lesion is 2 to 4 centimeters, or depth of invasion is more than 5 to less than 10 mm, 10 mm, or less than 2 centimeter tumor size with depth of invasion is more than 5 or less than 10 mm.
Right. So how did you arrive that you're giving it as C2? Okay, that's fine. So how do you decide on depth of tumor?
So depth of tumor is mainly can be assessed in MRI, sir, and in pathologically.
You think MRI? You think MRI can? You think MRI can confirm depth of tumor?
So it will be confirmed by pathological examination. But
So
it gives a broad idea about the
right. Okay, that's fine. In this AJCC 8, there have been some changes.
Yes.
In cancer.
So mainly it has involved extranodal extension, and depth of invasion has been involved in stage stages, and nodal metastasis has also included extranodal extension.
They have done away with T0 in AJCC 8.
Yes, sir.
They have done away with T0. T0
Yes,
has been removed. Why do you think it's been removed?
So
what do you mean by T0?
So there is no evidence of tumor, sir.
Right, very good. So you've got malignancy in the lymph node and nothing and no tumor. That has been removed from oral cancer. Why?
Okay, sir.
This has been removed from oral cancer, no T0.
No, sir.
AJCC 8 has removed it. Why?
So I don't know.
Yeah, because T0 is usually associated with nasopharyngeal carcinomas, right? They are usually associated with nasopharyngeal carcinomas. So they've removed it from oral cancers. It's been seen that they are usually associated with nasopharyngeal. So you have a lymph nodes which is positive, but no oral cavity lesion. So we generally seen that it's nasopharyngeal carcinomas which lead to this. Oral cancers don't lead to this. Right? You can't have no lesion in the tongue and still have lymph nodes. That's why. Okay, so now what is the management for this?
So multidisciplinary approach will be followed, sir. And,
What do you mean by
after that-
multidisciplinary approach? What do you mean by
So
multidisciplinary?
it involves involvement of various departments like operating surgeon, surgical oncologist, and radiation oncologists, and including rehabilitation of the patient. We also care for rehabilitation and
So
involvement
why do
of
you want to
dental
involve
surgeons.
all these people? Why do you want to involve all these people?
So because they have to after the resection we have to plan reconstruction of the deformity, and
You get a cancer surgeon or a plastic surgeon to do it. Why oncologist and physiotherapist and nurse and all the why all those people? Why waste the time? There may be some reason for it.
yes, because rehabilitation of patient is important, and we have to inform that it is a malignancy, and patient will there will be decreasing the quality of life of the patient.
Right. There are multiple ways of treating it. You can have a radiotherapy, you can have surgery,
Yes, sir.
right? After all that,
Yes.
there'll be some disability which you'll have to cover
Yes,
up.
sir.
Then you have to follow up the
Yes.
patient, right?
Yes.
So
Yes.
that's why you have to involve all these people.
Yes.
What's the blood supply of the tongue?
So it's a lingual artery, sir. It's a
Branch of
external carotid.
also. Is there any other artery? Tonsillar artery branch from facial also forms a collateral.
Yes.
Okay. You have the lingual artery and you have the tonsillar. What are the other branches of the external carotid?
So facial artery and superficial temporal artery and
No, don't start from top here. Start from below. Which is the first branch?
so superior thyroid artery.
Okay.
So that's ascending pharyngeal artery.
Yes. Then
Then followed by facial artery.
Hmm?
Facial
Which one?
artery, sir.
No,
Facial
lingual.
artery.
Sorry,
Lingual
facial.
artery.
Facial.
Facial
Facial.
artery. And the lingual artery. Then the palatine branches or tonsil artery, palatine branches, sir. Followed
No,
by super.
No, you don't have
Uh,
palatine branch.
Followed by superficial temporal and maxillary arteries.
Keep got it all confused anyway. Yeah. Okay. Now, how do you manage this patient?
Management, 1 centimeter circumferential margin from the indulation of the tumor will be taken. Wide local excision will be done, and with followed with elective neck dissection of level 1 to 3 group of lymph nodes will be done in this case.
What do you mean by elective neck
followed by reconstruction? Yes, sir.
What do you mean by elective neck dissection?
So because clinically lymph nodes are not palpable, and we are to prevent any chance of nodal metastasis, or there could be some ghost foci or metastasis could be there in the lymph nodes. So elective neck
There are
dissection.
no lymph nodes involved. There are no lymph nodes involved.
So study has been done, and the overall disease-free survival and overall and disease-free survival is better in cases
Can
of
you follow
elective
up the
neck
patient?
dissection.
Can you follow up the patient? Or is there any alternative to that? Is there an alternative to neck dissection?
So
Can you
you
do
can
something?
firstly perform sentinel lymph node biopsy of
Right.
candidate in this case, sir.
Right.
But
So
it is
for
also
early stage, for T1, T2, you must do a sentinel node, right? Though it is very difficult here compared to breast and penis, it's very difficult here, but you must do it, right? So, what are the risk factors for nodal mets?
Poorly differentiated degree of differentiation, sir, and lymphovascular or perineural invasion of the tumor, multiple, and cancer involving floor of the mouth or crossing the midline.
No. Tumor size. Tumor size, tumor depth,
Yes.
tumor grade, and neurovascular invasion. You get me?
Yes.
Tumor size, tumor depth, tumor grade, and neurovascular invasion.
Yes.
Right? Okay. So, do you think this patient has a good prognosis?
So, yes, sir, this patient, it is a early stage cancer, so it will have better prognosis, and overall, sir, lesion is also small, so we can also perform primary closure of the defect with less than 30% of the total length of the total incision of the cancer. Overall, it was presented early without any nodal metastasis.
Okay. You said you'll do a neck dissection,
Yes.
right?
Yes.
Which lymph nodes will you remove? Which levels?
Level 1, 2, 3 group of lymph nodes. So trauma,
Why do you have to do this? 1, 2, 3.
Because usually lymphatic drainage of the tongue occurs in level 1, 2, 3 group of lymph nodes.
They have the highest risk for occult metastasis. It's called occult metastasis. That's why you have to do a supramolar dissection in a clinically negative neck. Okay, quickly tell me the types of modified radical neck dissection 1, 2, 3.
So modified radical neck dissection will involve removal of level 1 to 5 group of lymph nodes. Along with in type 1, we spare the spinal accessory nerve. In type 2, we spare spinal accessory nerve with sternocleidomastoid. And in type 3, we spare all the three structures, including spinal accessory nerve, sternocleidomastoid muscle, and internal subclavian. And it is also known as functional neck dissection.
Right. Yeah, I think yeah. Any role?
What is the role of radiotherapy in neuroneck?
Yeah.
Hello.
Yes, sir.
What is the role of radiotherapy in treatment of neuroneck?
So the role of radiotherapy, sir, can be given in the cases if there is positive margin, close margin, or presence of any close margin, or pathological stages says presence of lymphoblastic.
Look, Karunendra, we spoke about
Yes,
field cancerization, didn't we?
Yes, sir.
That's why there's this role of chemoradiation.
Yes, sir.
Right?
Yes.
It's not just that's just the ulcer which we are going to manage, because there is there is field cancerization, which is very common.
Yes.
That's why there's the role. Okay. I think we can call it a day, sir.
What are different neck incisions?
So McAfee incision is given, and Solinger neck incision is given, bi-radiate incision, after incision, and the reverse J incision. Mayer's incision is given.
Okay, Karuna, I think you've done very well. Very well. Right?
Nice presentation.
Thanks.
Thanks everyone for your comments, and thanks Karunandra, you presented well.
Thank you, sir.
Very well done.
You would like to ask any questions, Pa? Any doubts?
Yes, sir.
Dr. Singh, KP Singh, you like to
No, sir.
ask any
No,
doubts?
sir. No, sir.
Kadar, sir,
I have,
any?
sir, I have, sir, one doubt.
Yeah, please.
Sir, should we give in this case in clinically feasible tumors? We should give, sir, radiotherapy, or we should do elective neck dissection in this case, sir? Because what I have heard, overall disease-free survival, and it is better in cases of elective neck dissection. So
You'll speak louder, Pa. Your question is not
Your
clear.
voice is very low.
Just louder, please.
sir, what would be the better choice in clinically, sir, N0 tumor, sir? It would be elective neck dissection or, sir, radiotherapy in clinically
So
N0,
surgery and
sir.
radiotherapy both are comparable.
So you are speaking about N0 neck dissection. Am I right or not?
Yes, sir.
He's asking
Clinically.
N0 is surgery, neck dissection better or radiotherapy? He's asking.
See, when it is N0, we have to confirm whether the node contains metastasis or not. That is what you said. For what you said, supraomoid or selective neck dissection has to be done. Then only we can find out that nodes contain metastasis or not. If it contains metastasis, and if our dissection is complete, then there is no need for radiotherapy and all. Okay. Because we are not doing a modified radical or radical neck dissection, we are only doing a selective neck dissection. Actually, it is a diagnostic dissection rather than a therapeutic dissection. Yes or no?
Yes.
So,
his
in
question
N0, a selective neck dissection
his question is N0 should we do neck dissection or not?
Yes, sir. N0 needs a neck dissection. That is a diagnostic neck dissection. That is what I'm saying. We have to diagnose that. That means N0 area, that is a supraomoid area, has to be dissected. We have to remove all the level 1, 2, 3, along with the submandibular gland. All these things to be removed and subjected for HPE to find out how many nodes contain metastatic deposit, or if there is no node containing metastatic deposit. If no nodes containing metastatic deposit, there is no need for radiotherapy or surgery. Further surgery is needed. If at all metastasis is present, if it is limited, this is adequate. If this is adequate. If there are more number of nodes containing metastatic disease, then we have to either go for modified radical neck dissection or radical neck dissection, or go for radiotherapy. As far as the nodal disease are concerned, surgery is little bit superior than radiotherapy.
Right, for primary also, IMRT can be given. IMRT is one of the modalities, but as a surgeon, it is surgery for both the primary and the lymph nodes. If there's any residual disease, can go in for radiotherapy or chemoradiation using cisplatin-based chemotherapy with radiation.
Professor Ganguly, sir, any closing comments?
No, sir. I'm really happy that the way he has tolerated stood up to the questionnaires, and thank you very much for challenging him and asking me all those questions. I'm really happy and learned a lot from my people. Thanks very much.
Thank you, sir. Can we close, sir, with the permission of the faculty?
Yes,
sir. Good night,
sir.
Good night,
Good night, sir. Good night,
Good night, sir.
Thank you very much.
Thank you, Singh. Thank you, David. The thing. Kanavel sir, can we close?
Yes, yes.
I think he's there, but he is. So he will close. Thank you, sir. Thank you all. Good night, sir.
Thank you, sir. Good night, sir.
Thank you.
Subratri.
Good night, sir.